Welcome back to Medical Monday. I'm here with Dr. Dan Wonder. He's an interventional radiologist, and I ask you every time you hear, explain exactly what that is, because we're not used to hearing that.
I think the best way to explain it is a minimally invasive surgeon, really.
Okay.
I mean, radiologists are trained in imaging, ultrasound. I mean, that's our basis. That's how we make diagnosis on people. You know, X-ray, ultrasound, CT, MRI, etc. And what interventional radiology is, a blend of that as far in a minimally invasive procedures where we can do tremendous things inside the body through tiny little pokes, you know, in your skin, anywhere in your liver, your arteries, to help fix things inside you. All kinds of tools have been developed to put stents in, ablate liver tumors, kill off liver tumors, all things like that. You know, I mean, it's just really a wonderful field that began in the 70s, mid-70s, basically.
And your dad, right? Am I remembering the story correctly? Was an interventional radiologist?
He was a radiologist.
He's a radiologist.
Yeah,
okay.
He was. That was before actually they had interventional radiologists. So he learned. You know, he was the. You read the films and the CTs and the ultrasound. So. And
you have at least one son following in your footsteps?
Yeah, one's in medical school right now, yeah.
Oh, that's pretty cool. Very cool indeed. Yeah. Okay, back to the topic at hand today, uterine fibroids. Women who suffer from these are often in a lot of pain. They're dealing with heavy periods. And when we say heavy, we're talking heavy periods to the point where it affects your lifestyle. And you do a procedure called uterine embolization. Can you kind of just give us the overview again if people are just joining us here at about 7:30? What is that?
Sure. Embolization is a process, it's a fancy word, it blocks blood flow, it blocks flow of something. And when we put these tiny little straw-like catheters in the arteries and steer them around, we can put them in different places, and we put material through those catheters, sterile material, to block the blood flow wherever it is, whether it's in the liver or the uterus or the prostate or a bleeding vessel in a trauma case or something like that. We can stop that without you going to surgery, basically. So fibroid embolization, you have these benign, non-cancerous tumors of the uterus, and they're causing problems, mostly bleeding, but other symptoms also. And you are, you know, in a very non-invasive fashion, minimally invasive, I should say, you know, starving them of blood flow, making them shrink so that they quit bleeding or markedly reduce their bleeding. So.
And this is highly targeted. You're not going to affect the entire uterus per se, right?
Well, yes and no. Yes, the uterine artery is what you embolize.
Okay.
But whatever's in the uterus, a fibroid, is dilated the blood flow to it, so it's sucking most of the blood flow to it. So when you're done, the blood flow isn't going through those arteries much anymore, but there are a lot of other tiny arteries going to the uterus, so the uterus doesn't die. You're basically, you know, embolizing the area that's the most vigorously growing, I guess you'd say.
Now, even though you're starving these uterine fibroids of their blood supply and blood flow, they don't then just kind of fall off and die of what we would think of, like, you know, if you put a tourniquet on your arm, eventually it's going to fall off if you just did that. But that's not what happens.
Well, in very rare circumstances it can. In very rare circumstances you could actually pass a fibroid like during your period.
Okay. I
mean, they're small and they can come, if they're located on the inside of your uterus. The fibroids are either in the middle of the muscle of your uterus, they're on the inside next to the lining of your uterus, or they're on the outside of the uterus.
Okay.
So it is possible to pass a fibroid or for it to fall off. It's very rare. They used to worry about that a whole bunch, what they call pedunculated fibroids, kind of like a stalk.
Sure.
They worried that if you embolize those, the stalk would, you know, necrose and poop falls off somewhere. They don't really see that very much, quite honestly. But some of the inside ones can come through. It's not real common, and I don't know how often it's not. I think it's been reported to me once by one of my patients that they noticed a little more tissue at one point than normal. But most of the time what you're doing, the vast majority of the time, is that fibroid, you're shrinking it down about 30%, which is a big change in volume. And if you have several of those, you know, a uterus that feels this bulky gets like this, it's like a world of difference to a lady. So.
Okay, let's hop to Rowena. Rowena, thank you for your patience. What's your question tonight?
My question is, what size fibroid would be too large for the
embolization? It is a mouthful. I tell you what, Rowena, great question though. What size is good or bad?
as I think I said before, about 20 centimeters. I mean, was kind of the rule of thumb. We try to stay that size or below, just because the bigger they get, the bigger a risk they have of becoming infected in the middle. And that's still not big. And I've done plenty of them that are that size. But that's kind of at least where I kind of try to draw the line, because it's so big, it's hard to get all that blood flow stopped in a fashion that's pretty safe. So.
Okay. So with 7 centimeters, would that be good?
Yes, ma'am.
7 centimeters.
Yep, that's good.
And Rowena, if this is something that you're dealing with, we're going to put up numbers here at the end of the broadcast here, so go ahead and get your pen and paper ready. We'll tell you how to get a hold of Dr. Wonder so you can discuss your options a little bit better and understand what this all is about. As folks deal with this and maybe do the embolization, what can they expect in the week after to the 6 months after this?
The initial, the first couple of days, and I've said, it can be kind of difficult, like a real bad crampy period.
Yeah.
Most women, it kind of varies, like from not noticing too much of anything other than a pretty difficult period to there's some women that have a good amount of pain. Caucasian women usually have a little bit more pain than African American women. I'm not sure why, maybe, but I noticed that over the years. But after that first couple days to 3 or 4 days, then they pretty much go about their normal activities. I haven't been any feedback we've gotten in the clinic hasn't said that they've changed things much. The biggest question is, what about the bleeding? The bleeding tapers off. It just doesn't stop automatically. It tapers down. Okay. So that's kind of one of those things that'll improve over time, and it can take up to 4 weeks to 6 weeks to taper down to something that's more.
This is bleeding after the procedure, or bleeding with your period that may be especially heavy? Bleeding
with your period. You're not going to bleed after the procedure.
Okay.
You're not. Sorry. It's your normal menstrual cycle is going to get lighter and lighter, basically. Trying to get back to a normal menstrual cycle, not a really heavy cycle.
So that would take how long again?
It could take 1 to 2 cycles potentially.
Okay.
When they start to really see, at least what we've seen in the clinic, it's more improvement at 4, 6, 7 months, where the fibroids are starting to shrink down, and then there's some of those other secondary symptoms like urinary frequency, because that uterus is being squished on the bladder, and some of those other things like that. The pain in the pelvis, that's going to start to get better and better, but it takes a little while for that to happen. It's not tomorrow.
Right. And you're going to see there on the MRI or the ultrasound, you're going to take the measurements before surgery and then after, and continue going and say, actually, they've shrunk this much. Yeah. So it's often good to actually see the evidence, what's happening inside your body. We have Terry on the line. Terry, good evening to you. What's your question?
Hi. I was actually wanting to know, is there a lot of downtime on that, and is it actually surgery? Are you going in for like an office visit, or is it something you have to prepare to be out of work for a while?
All great questions.
Most women have this procedure done like on a Wednesday or Thursday. They come into the office. Yes, it is an office visit. We usually have that sometime a week or 2 beforehand, because of the pre-certification process with insurance company. They have to document all this so that we can get it approved for you. And then so when you come in and have it done, they usually pick the middle to end of the week and have some days off, so that by Monday, after 3 or 4 days of rest, they're ready to go. Now some women want a little bit more time, and most of those women know that they need more time to recover from things, and then they plan it as such, maybe like an extra week off or something. But it is not a surgery; it is a procedure. So you will be sedated. You will need a driver.
Are you knocked out sedated, or are you kind of like loopy sedated?
No, you're snoring sedated.
Okay, gotcha.
Yeah.
Okay.
So you don't remember it. I mean, those drugs are given so you don't remember it. You'll need a driver, and there's going to be one little incision that's about 1/8 of an inch next to your groin on the right side. Usually, that's where all the work was done from, and you have a little bandage on that you go home with, and you take off the next day. So, I think is that all your question was, ma'am?
One more. Okay. Will this one procedure take care of all of the, is it a one procedure for all of the uterine fibroids that you guys noticed inside, or is it going to be more, you know, will I have to go back? I think I have about 8.
Okay.
So I guess my question is, will all 8 of them be removed if I decide for this?
All 8 of them should receive the therapy that's put through the catheters. Okay, we can't select out 1 or 2 or 4. I mean, it's going to get therapy from both sides, your whole uterus. Now there's about a 5% rate of having to redo this within a year if your symptoms still haven't got to where you want to be, and we need to go after them again. But so they'll all be treated.
Terry, thank you for calling in with some great questions tonight. Really appreciate hearing from you. And that was a question I had during one of the breaks. Do people have one fibroid, or do they usually have more than one? You said definitely more than one.
Yeah, usually it's pretty rare just to have one, but it's possible. But most of the time they have multiple fibroids.
And again, you said there's no rhyme or reason why this happens to women, right?
No, it just happened. I mean, we don't. There's some mild correlation with increased weight. There is some mild correlation with lack of exercise. So they say that, and African American women usually have more fibroids than Caucasian women. So, those things you could do to help yourself. And there is kind of a familial predominance to it too. So it does run in families some. Oral contraceptive use does not cause fibroids to occur. Okay? There's kind of a misconception that's out there at some point. So.
Okay, all good to know. And great questions. I think that people, you can definitely tell that women want to know, what are my other options? Maybe I don't want to have a hysterectomy for whatever reason that may be. You still want to have children, or you just don't want to have a big surgery like that, because it is a very serious surgery.
Yeah, it's a big surgery.
Yeah. All right, we're going to take another quick break. When we come back, more of your questions and calls. That number to call, 615-737+. We will get those calls lined up during the break. Stay with us.